Hi everyone. So today we are going to talk about the basic difference between the UMN lesion versus LMN lesion. So firstly, the site of the lesion in the UMN will be cerebral hemispheres, in that it can be a stroke or any of the cerebral pathology. It can be a cerebellum involvement, brainstem involvement, or the spinal cord involvement. In LMN type of lesion, it can be the involvement of the ASC, that is the anterior horn cell, involvement of the nerve roots, peripheral nerves, or the neuromuscular junction. In upper motor neuron, I have mentioned the spinal cord because if the spinal cord pathology involved the corticospinal tract, then it may lead to signs and symptoms of the UMN, because CST, that is the corticospinal tract, it is an upper motor neuron mediated tract. So if that spinal cord pathology involves CST, then we are having UMN type of lesion. Secondly, muscle weakness. In UMN, it can be quadriplegia, hemiplegia, paraplegia, or diplegia. But if it is a element, then it can be two types. If it involves muscle, it can be a myopathy. If it involves nerve or demyelination, it can be a neuropathy. Third will be depending on the muscle tone, it can be a spasticity or rigidity. Spasticity is velocity dependent, means as soon as we increase the movement while checking the tone, the spasticity will increase. The rigidity, in contrast to the spasticity, is non-velocity dependent. Means the rigidity will remain same even though we are increasing the range of motion during the assessment of tone. Spasticity, it is a characteristic feature of stroke, while rigidity is a characteristic feature of basal ganglia involvement. So, rigidity is a hallmark of Parkinson's disease. While if we consider or if we talk about element type of lesion, it is having hypotonia. Now, fasciculations. In UMN, it is absent. In LMN, it is present. The reason that in LMN the fasciculations are present, because as the muscle is getting hypotonia, the muscle will lose the contraction, and as the receptors on the muscle will become hypersensitive to the acetylcholine neurotransmitter. So when we have patient is trying to perform the movement, at that time that ACH sensitive receptors will start excessively working through the action potential, and that's why it will have a fasciculations. So in LMN the fasciculations will be present. In UMN the fasciculations are absent because it is not any lower motor neuron, or it is not any receptor mediated, or it is not any muscle contraction failure disease. It is because cerebral cortex or the higher nervous system is not able to transmit the information to the lower motor neuron. That's why fasciculations will be absent in UMN. If we talk about the tendon reflexes, then in UMN lesion it will be hyperreflexia. So there will be an exaggeration of the response. While in LMN there will be, it can be hypo or it can be areflexia. Hypo means decreased reflex. Areflexia, it can be an absence of reflex. As the muscle are hypotonia and as the nerve is getting demyelinated, or if it is a myopathy, the muscle is failed to contract. In that cases, the muscle, despite having an control from the upper neurons, upper central system, but it is failed to contract because the muscle is not getting in proper excitation from the nerves. So that's why they are having, it can be a hyporeflexia or it can be a areflexia. If we talk about UMN, then the characteristic we always consider is stroke condition. In LMN, it is always the peripheral neuropathy we consider, but it can be having many of the diseases. Like in upper motor neuron, if we talk about the cerebellar pathology, then also we are able to elicit this sign. If we talk about in brainstem disease, then brainstem disease many a times it is having an involvement of the cranial nerve nuclei, it is having involvement of the tracts, various tracts. So brainstem is having a mixed sign of upper motor neuron as well as a lower motor neuron. Spinal cord similarly having the same. Poliomyelitis, if we consider, then it is a condition of the lower motor neuron disease. If we talk about the myasthenia gravis, then it is also a lower motor neuron type of disease, right? So next will be the abdominal reflexes. In UMN, it will be absent, while in an LMN, it will be present. Now, this abdominal reflex in LMN, it will depend on the site of the lesion. If it is a spinal cord injury case at the level of T12, then it may be absent because the T12 level of a vertebral column, there will be a spinal cord center of the reflex will be mediated from T10 to T12. So if it involves that segment of the spinal cord, then the reflex can be absent in that condition also. Sensory loss. The most important thing is UMN is having a cortical sensory loss, while LMN is having peripheral sensory loss. Means peripheral sensory loss means we are able to get an absence of sensation in particular dermatome. But if we are taking an assessment of sensation for UMN type of lesion, we don't have to go through dermatomal pattern. We just have to see whether the sensations are present or not in the affected part. So if I talk about a case of stroke, and if it is a right hemiplegia or right hemiparesis, then I will go for assessment in right side of the body that whether the sensations are present or absent, but I will not check according to the dermatomal pattern. That is the main difference. If we take an EMG analysis, then there is a normal nerve conduction because peripheral nerves and everything are intact. So there will be normal nerve conduction, decreased interference pattern and firing rate. This will be seen because the the cerebral cortex is not able to give sufficient information to the muscle, and that's why the interference, the muscle contracted will be decreased and the firing rate will also be decreased. While in LMN there will be an abnormal nerve conduction, there will be presence of fasciculations and fibrillations. Muscle mass in that there will be in UMN type of lesion it will be maintained, while in LMN type of lesion the muscle wasting will be present. This is also an important point that we have to see in the clinical assessment. The muscle mass is maintained in UMN type of lesion because the muscles are hyperactive. They are because of the spasticity, the muscle is already in hypercontracted state. So the muscle mass is going to be maintained, while in LMN the muscle mass will gradually decline, and this muscle wasting will lead to muscle disuse atrophy, right? So the basic difference the UMN is having the involvement from the cortex. It can be involvement of cortex, it can be involvement of basal ganglia, it can be involvement at the brainstem level, or it can be involvement at the spinal cord level. So there can be an involvement of the corticospinal tract from the brain to the basal ganglia to the brainstem or to the spinal cord, right? If it is an involvement of basal ganglia circuits, then there can be rigidity present. In LMN, you can see this is the spinal cord. This is a mixed nerve. So if there is an involvement from the anterior horn cell to the spinal nerve, any damage in between, it will lead to LMN type of lesion. I hope you all understand this video, and thank you.